Thank you. It is my pleasure to introduce Mr. Declan Dunne. He's a pancreatic biliary surgeon in one of the highest volume pancreatic units in the country in Liverpool. He has been and he's the driving force behind the development of the robotic service in Liverpool. So we are all looking forward to hear his thoughts on robotic Whipple's procedure in a step-up approach. Thank you.
Thank you very much for that introduction. So I was asked to talk particularly about robot Whipples and how the step-up approach that Jawad developed. Where's Jawad? There. So, I mean, his approach to this, because Whipples is a different beast. So disclosures. The first thing to say is I was involved in a polytrauma in 2013. It was a bad time. It was a bit grim, but my career will be prolonged by robotic surgery. So I am completely biased. So that's the important thing. So I don't have lots of disclosures, but I am utterly biased. So now, well, today's talk, I'm just going to talk a little bit about why we sort of did it, sort of where we did it in terms of what our centre is, how we were, so who we are, obviously Declan, and then how we approach it with really the step-up approach. And then I'm going to talk about our data because it's not all good. You know, it doesn't all go your way. So the first thing says, our journey really started when we went to Utrecht in January, and Ryan was really the convert at that point. And then I went there and I watched a Whipple being done faster, better, and more precise than I could done, including a 40-minute break when we all went up to the canteen and left the patient on the table, and we still finished at like 2:30. So it was an ampullary adenoma. It was a patient who was thin. You know, it was the unicorn, the non-existent creature in Liverpool. But that was the two-consultant approach, and actually a lot of it was done laparoscopically with the robot assisting, particularly in the resection. So it's not quite the same as what we do, but that I was, you know, an instant convert. I was like, that's better than what I can do. That's the future. This is what we have to do. So after that, I then sort of got very involved with robots. And actually, COVID was great for me because I actually got loads of time to go on the simulator because the simulator happened to be free because the robot wasn't in use. But so when we started looking at it, we're looking at the data. So 2015, this is patients up to 2015. So this is 10 years ago. There you go. So these are experienced surgeons beyond their learning curve. They're getting 200 ml blood loss conversions, sort of 1 in 20. Length of stay, 8 days. And I know length of stay in the States doesn't necessarily translate because it's a slightly different model. Complication rates, it's still a morbid procedure. Yeah, and their mortality 1.9%. So then the Dutch group, helpfully, they published last year. So their mortality, again, nearly 3%. And again, these are all in high volume centres in surgeons beyond their learning curve. So we've then got the first randomised trial in robotics was published last year. So 3 high volume institutions. Now, all these surgeons are past their learning curve. And their learning curve was defined as per surgeon, 60 open Whipples and 40 robotic Whipples before they got into this trial. And this was 5 surgeons, 164 patients randomized over 9 months. So this is seriously high volume. And okay, their mortality is 1%. Okay, and that was the same for both open and robotics. So in Liverpool, we're a specialist pancreas centre. So we do about 200 resections a year, 105, 110 Whipples a year. It fluctuates a little, but it's roughly around that sort of number. The robot access that I managed to negotiate was a list every other week. That's all we've got. And our outcomes are good. You know, so our length of stay is 12 days. It's been that, to be fair, for about 10 years. It's gone up slightly, if anything, more recently because our ITU is not being as good. But our mortality is 1% or just under, and it's been that for 10 years. So that really, when you're looking at these high volume centres beyond their learning curve, and I'm talking about setting up a robotic program. So, I mean, this is, yeah, if I start having 4 or 5% mortality in the robot Whipples, I'm going to be stopped. That's not acceptable. It's not acceptable for patients. It's not acceptable in the unit. It's just not right. So setting up that was really stressful, sort of trying to get a program up and running beyond a learning curve without compromise. So that was really the challenge for us in Liverpool, was worse because our results were already good, and that really was the challenge. So we hopefully had Jawad's step up approach, and this was really, you know, everybody who's done robotics will be involved. So he's published this. This is a really nice way to approach. So first of all, you've got to get approvals. You've got to do 20, 30 hours on the simulator. I would say I've done probably 80, 100 hours over COVID on the robot. So I told my wife, you know, she's homeschooling, got to go in today. It's very important. I've got important things to do. I'm playing computer games. So it was, you know, I really benefited from that COVID. So the first thing, you've got level 1. These are easy cases. You're not trying to make it difficult. This is really to get your theatre team and you just used to having the robot and what it is. You're then moving to level 2. Now, for us, level 2 was a bit of a problem because we only do 30 to 40 distal pancreatectomies a year, and we don't actually have any other level 2 cases, you know, to do. And if you take all your level 2, then you're doing cases that you wouldn't even do normally. You wouldn't consider doing lap, and you're doing them on the robot. You know, so I think my first robot distal was a ramps, you know, because that's just the case that I had. It was a relative unicorn other than the proximity to the celiac axis, but you know, that was a bit of a slow time for us. And then we get to Whipples, and then you're doing an additional training course, and then 4 to 6 suggested proctored, though actually we had 2 to 3 each, I think was what we had. So So the first thing to say is having that extra person is really, really important. A Whipple is a different beast. It's not something you do laparoscopically, and having Ryan on board, you know, we trained together. We were appointed within 3 months. Yeah, and that's actually him on his wedding anniversary when he was with me in Stockholm on a robotic course. For the 3rd year in the row, he was away on his wedding anniversary with me doing robotics. I would hazard to say. So it's 3 and 4 years he went away for both his birthday and his wedding anniversary. He was with me, but having him on board is really important. You also need those partnerships. You need to get on board with industry. You need to work well with your proctor. You know, and the answer is yes. When somebody rings and says, "Oh, we've got this day for proctoring," you say yes. You then sort out the fact that it was your daughter's birthday. You were on call. You were moving a hospital, you were the clinical lead. All of that stuff is secondary. You say yes first. You need those good relationships. You need to learn to say yes. You also need everyone else on board. You know, so if people in your department are not impressed with your idea to do robot Whipples and you go off and you have any problem, you're not going to get support. You're going to get stopped. So you need to get everybody on board. You all need to be working towards the same thing. Yeah, and it's really important to get everybody on board, and that's your theatre team, your managers, your colleagues who are not on the robot, who might not be impressed that they're not on the robot. So it's really, really important to get that going. And then when you get going, I mean, anyone who is following me on Twitter will have seen that when we were going, and I'm a lot quieter more recently, but I was tweeting all the time about all the great stuff that we were doing, our robot gallbladders on a weekend, you know, and yeah, yes, but these are things that, you know, for the staff in theatres, you're getting this publicity, getting a little mention in the hospital magazine. These things are early wins, and it's important to get that positivity going and keep going forward and being positive. So for us, so our training timeline. So my first level 1 case was November 22. Course was the day before. But we had 2 people fully proctored at level 3 doing Whipples within 13 months. And the big slow thing for us was that level 2, because there's only so many cases, and that getting cases and the proctoring days together was a little bit tricky, but that was the thing. So that was our timeline. So how did we get on? So our first Whipple was July 23. Our 26th Whipple was March 25, so just recently. So what are our outcomes? So our blood loss is about 150 mils. So that's our sort of median in quartile range. Our upper limit is a litre. That is our only conversion. And where's the other half? I still blame him. So we're done. we're done the Whipple for the ampullary adenoma, and Brightspark says, do you know what, that one lymph node on the SMA, you know, in this patient with multiple antibodies who we've only got 2 units of blood available in the north of England, that one lymph node definitely looks abnormal. You definitely need to take that off the SMA. I have that video, and that is our only conversion, and it's still his fault. So our length of stay is 13 days. Yeah, so actually it's not much better than our open patients. And broadly speaking, when you look at, so length of stay is they have complications or they don't. If they have complications, they stay longer because they're having leaks. They've got delayed gastric emptying is the big thing that we see when they have a leak. But actually, you know, we've got patients who are going home day 4 after a Whipple. Yeah, you know, that's one of the key things that we see. We've had a couple of pseudoaneurysms. We've not had a mortality yet. We've had a couple of close calls, but it's the failure to rescue. So our unit's quite good at picking up when people are having bleeds and things, and you know, it's not all been good. So one thing that I've particularly picked up on is there are some times when your colleague books himself into an on-call, not realizing he was meant to be assisting you in a Whipple or doing half a Whipple. And then also I've happened to abandon my colleague for a few months. But when you look at the people, the 1 surgeon versus 2 surgeons, having 2 surgeons in theatre who respect each other and actually can challenge each other, because that's the thing you don't always get from the trainee, even if they're a good tableside assistant, makes a difference. So if we look at the 1 surgeon versus 2 surgeons, so we've got 6 patients versus 20. Our operative time is longer for the 6 patients. The length of stay is much longer, and they've all had complication. All of them have had a significant complication, and actually our leak rate is high. Everything is higher, and I think it comes from, if you've done the resection and you're tired and then you're doing the reconstruction, it isn't as good. And I think that's one of the key things. So I think the 2 surgeons really makes a difference, and having that support is really, really key. So I would say that we're significantly behind in pancreatic duodenectomy. I think the learning curve is probably going to be somewhere in the order of 40 to 60. I mean, yes, you'll get some crossover from doing your totals, your pancreas-preserving duodenectomies, and all those other cases that we can do. I think the step approach is the only way that we should be doing it. I think you need the team support. And then the other thing is, I think volume. I think if you're not all in, I think it's one of the comments we heard yesterday, if you're not all in robot Whipple, you shouldn't do it. And I think really we should be probably looking to be doing 20 per surgeon who's a robot surgeon per year is what I'm getting as a feel from the literature. That's what I think we're probably talking about. So if you've not got that volume, I wouldn't even start. I think there is probably a lower leak rate. Our leak rate is lower than we would expect on our Whipples. I think the anastomosis, particularly the PJ, is better. And we have got some patients who are not having complications going home really, really quick and recovering so well. So I think it is the future and it is better, but it's going to take time. And I think, yeah, I think maybe you need that volume. And thank you very much for giving us the time. And I just quick note to the guy in the middle here. So that's Peter Satsbury. And you do some bargains. There's lots of bargains go on when you're doing this. And one of the bargains is that he gets his face on my robot talks. So he covered my on-call on 2 proctoring days at very short notice. So he gets his face, and that was his bargain. So I didn't have to pay him back on the on-call, but he gets his face on my robot talk. So that's my consultant colleague who's very helpful. And pizza, I brought the 13 pizza every time we did a robot case on a weekend. So that was the other thing that I did a lot of. And Intuitive brought me a cake when I did my 100th case.
Hi, I'm Emmanuel Meloul from Switzerland. Thanks a lot for a great talk. I just wonder, when I talk to people doing a lot of Whipple robotic, a lot of them say that when you have a fistula, the fistula is worse than when you do open, probably because you don't have a lot of adhesion after the surgery. So what is your thought about that?
So the cases that we've been, because we're quite high volume, we do have some selection. So the cases that we're doing on the robot, nearly every single patient has a soft pancreas and a small duct, you know, and these are the cases we would expect bad leaks. So we haven't really seen that. So I think the anastomosis has been better. We've had a couple of pseudoaneurysms, but often I mean, one of them was like day 1 post-op, so I don't think that's a pancreas leak that's caused it. And then another one, we're having complication we wouldn't see with open whipple. So we had a patient who involved the entire small bowel around his PJ, around his GJ. You know, we had a scan and everything looked dead, and we took him to theatre, just untwisted it, it was all fine. But then he ended up with all sorts of weird complications after that. He had a horrendous time, but that I don't think we would have had that. So that's a complication we've never seen in an open whipple ever. And I think that from nothing being stuck down, everything was mobile. I think that happened. But pancreas leaks, that's not been a problem for us. And I know Zahir had different experience, but I think, yeah, but everybody's numbers are small, but we haven't had really lots of really bad pancreas leaks. We've had a few problems. We've got, you know, I mean, we've definitely had problems. I mean, we've had complications we've never even seen before. But yeah, pancreas leak hasn't been a problem for us. I know that was a problem, obviously, in the Dutch study that was stopped. That was the consequences of the leak seem to be greater because of the minimally invasive approach. I mean, maybe that'll happen, but our leak rate seems to be pretty good actually on the robot. We've had more bile leaks than we'd normally have.
Okay, one final comment before our next speaker.